listeners, thanks for tuning into The Spark, Medical Education for Curious Minds, where we present the people and stories behind medical advances at UCSF, including those led by medical students, physicians, and faculty in the School of Medicine. Through The Spark, we share the innovations at UCSF that are helping bring more equitable and better care to our communities. I'm Karen Fleming, Communications Manager for the Office of Medical Education.
And I'm Greg Gadwood, Instructional Designer for the Technology Enhanced Education team.
In this episode, we showcase the latest research and patient care initiatives at UCSF and its School of Medicine focused on treating people with Alzheimer's disease and dementias, including student work in this area. We'll hear from Dr. Howie Rosen, a behavioral neurologist and professor of neurology. He directs the California Alzheimer's Disease Center at UCSF. We also speak with David Durevsky, an MD, PhD student who recently finished the preclinical years of medical school at UCSF. David will be starting his graduate training in February 2019. So I'm here with Dr. Howie Rosen, and we're here to talk about his work and research in Alzheimer's disease and dementia. So Dr. Rosen, what sparked your interest in the research and treatment of Alzheimer's disease and dementia?
So actually it's a long story, which I'll try to keep short, and it starts in medical school. I graduated in 1989, and throughout medical school I was really interested in neurology, particularly because of just a fascination with the brain and how it, makes behavior happen, how it mediates behavior. I finished a full internal medicine residency and then decided I was going to go back and do a neurology residency. And it wasn't until I came to UCSF to help Dr. Miller, who started our program, to build this memory and aging center that I work at now, that I became particularly interested in Alzheimer's and dementia. I've learned that it's a problem, a medical problem that's reaching epidemic proportions, and that will continue to grow over time. We really have very little ability to treat or alter the disease course right now. I would consider a lot of the work we do as palliative in the broadest sense, meaning trying to help patients and families cope with this disease rather than really influencing the course of the disease itself.
What do you see as being some of the toughest challenges in treating people with Alzheimer's disease and dementia? And I know you referenced that right now we're looking at a palliative approach.
We've learned a ton about the evolution of dementia from a neuroscientific perspective over the last 20 years. And we certainly know that neurodegenerative diseases that cause dementia are due to the accumulation of proteins in the brain that cause the nerve cells to malfunction and the nerve cells to die, and that's what causes the symptoms. So our real goal is to develop drugs which stop that process, and we don't have those drugs yet. And so the biggest challenge is to try to help patients as much as we can without the benefit of those drugs. On the other hand, there are a lot of other challenges that even if we did have those treatments, that we have to recognize and deal with. One of them is the fact that not all dementia is due to Alzheimer's disease. Alzheimer's is a specific syndrome that's due to the accumulation of specific proteins, but there are other proteins that can accumulate that are different than the ones in Alzheimer's, and they cause different sets of symptoms, different syndromes, and they're equally devastating in terms of the effect on the patient and on their family. When we develop treatments for Alzheimer's disease, they won't work against all those other dementias that I mentioned. So we will lose a lot of opportunities to treat people by considering that they had Alzheimer's disease and not recognizing that they have another disorder which could be adversely affected by drugs meant to treat Alzheimer's disease, or that they missed an opportunity to get a more specific therapy for them. We're facing such an epidemic because right now expert centers like ours already have very long waiting lists for evaluation. For instance, in our clinic, a waiting list is up to 6 months, unless we really perceive an emergent need for a patient to be seen right away. And in other words, that really would be most beneficial for a center like us, which would have more opportunity to evaluate them, maybe use specialized techniques. And I don't think we have a good system for that. I think out in the community, there's still a lot of nihilism and shying away from diagnosing dementias early and accurately.
What would you say to a medical student considering specializing in this area?
It's very gratifying in many ways. I think, first of all, my original concern that this would be a depressing field that I didn't want to go into, I abandoned that idea a long time ago. I think medicine is full of situations where you wish you could do more for people, and it can be very disappointing to not be able to provide that. But one of the things I've learned is that most people facing these diseases are quite resilient, and they're often quite realistic about what they can expect and can't expect, and they're very happy to have you provide to them whatever you can provide. And sometimes that's just education, sometimes it's other kinds of support. Anything, in our case, it's often anything to make their life easier.
Now that we've heard from Dr. Rosen about his research and new treatments being used at UCSF to care for people with dementias, let's hear from medical student David about how elements of the Bridges curriculum are helping learners understand the mechanisms underlying these brain illnesses and how to care for and support patients who have developed dementias. David will be starting his graduate PhD training in February 2019. So David, what sparked your interest in the research and treatment of neurodegenerative disorders such as Parkinson's disease and psychiatric conditions such as addiction?
So back when I was an undergraduate student, I had a chance to work as an in-home caregiver for the elderly, and one of my patients had Parkinson's disease. And not only did I have a chance to witness the toll that the disease had taken on her body, but I had also seen the strain that it caused for her family. And after this experience, I became very motivated to pursue neuroscience research. And after emailing several PIs at UCSF and at other universities in the Bay Area, I was very fortunate to have been welcomed into the lab of Dr. Frederick Hopf, over at UCSF in Mission Bay. And in Dr. Hopf's lab, I was given the opportunity to study circuits and signaling as they related to compulsive behavior in addiction.
So while taking courses or electives on these topics for the Bridges curriculum, what were some of the key themes or issues that you learned about? And please feel free to describe any special training experiences in this area.
So one of the unique aspects of the Bridges curriculum is that we're taught to think about the whole patient, not just about a certain disease or condition that they're coming in to see us. So, for example, even though in the brain movement and behavior block, we got taught a lot about dementias and their pathophysiology, their diagnosis, and their clinical management, there are a number of other blocks in the Bridges curriculum that are very important in teaching us to care for the whole patient. So, for example, we know that dementias are sort of long-term chronic diseases, and so it's very important for us to have conversations with our patients about their wishes for end-of-life care and what their priorities are. So through CMC, we've been taught very important skills about things like shared decision-making and how do you go into the literature to collect evidence and interpret evidence that helps you make the best clinical decisions on behalf of patients. Now, at the same time, we've also been taught to think about how patient care fits in with the broader healthcare system as a whole. And through blocks such as health in the individual and health in society, we've really been taught to think about disability and what it means to live with disability and overcome disability. I've also been really touched by this concept of caregiver, what we can do what we can do as providers to help support our caregivers in the best way possible.
What are some of the unique ways that you, as a physician scientist in training, can directly impact patient care at UCSF?
One very unique way in which we can do this is through a program called the Molecular Medicine Service, which is where a bunch of MD, PhD students get together and help doctors at UCSF crack really complex cases of patients who have rare diseases or even diseases that have not yet been diagnosed before. And what we do is we get together with the doctors, we review patient charts, we might get blood samples or DNA samples, and then we take all that back to lab and use all kinds of techniques to hopefully either help find some potential therapies that could help the patient, or at the very least help end a diagnostic odyssey for a given family that may have been ongoing for many years. Some of the other unique ways in which physician scientists can impact patient care at UCSF is through our unique collaboration with UC Berkeley, for instance, through the Center for Neural Engineering and Prostheses, which has allowed us to develop a number of very interesting approaches to neuromodulation that are now being applied to Parkinson's disease, depression, and chronic pain. I also think UCSF is very unique in how we partner with industry through things like the QB3 over Admission Bay, where we can take the discoveries that we, as graduate students and postdocs and PIs make in our labs and work together with industry to actually help bring them to clinical practice.
Can you describe a fairly recent moment in either caring for a patient or helping plan their care path, or in your learning experiences in the Bridges curriculum that was especially powerful, inspiring, or poignant for you?
So one of the most rewarding parts of the Bridges curriculum has been the preceptorships that we've been doing in the first year of medical school and continuing into the second year. During my second year, I had several neurology preceptorships, during which I had a chance to see several patients with brain tumors. And some of them were doing exceptionally well after surgery and had a very favorable outlook, while others, unfortunately, did not have as favorable of a prognosis. And in seeing these patients, I really came to realize the role of the physician as a healer. Not only can we hopefully treat and address the physical manifestations of illness and get patients on the road to better health, but we can also sit down with the patient and talk to them and listen to their story and hear their thoughts and express our empathy and understanding for what they're going through. And I think this is truly a magical aspect of medicine, where it's not just what you do in partnership with the patient, it's also how you make a patient feel.
How do you plan to integrate your study of the brain with your clinical and research training as a future physician scientist?
So one thing that I think makes the human brain, perhaps from a philosophical perspective, unique compared to the brains of other mammals is our capacity for creativity and for empathy. And as a scientist, I really hope to be creative in how I approach movement disorders, such as Parkinson's disease or dystonia or essential tremor, from the perspective of fusing together sort of the various aspects of science that interest me. For example, I really love this intersection between neuroscience, computer science, electrical engineering, and bioengineering. And I really hope to bring all of these areas together in the service of developing new deep brain stimulators that can help us manage patients' motor and also more sort of psychiatric symptoms of their illnesses better. In parallel with this, I think one of the most rewarding aspects of medicine is the empathy that we can show to our patients. And I hope to take this feeling with me every single day into the clinical work that I do, where I strive to take care of not just sort of the physical patient in front of me, but also the holistic patient, right?
After hearing these interviews, I have a better understanding of just how complex it is to treat brain illnesses such as Alzheimer's disease and dementias. How common are these illnesses?
Recent stats suggest that within the United States alone, there are over 5 million people currently living with age-related dementias. As the population increases, these numbers are expected to rise. To put this in perspective, it's estimated that 1 out of every 6 women and 1 out of every 10 men living past the age of 55 will develop dementia. Although there are various forms of dementia, around 70% of cases are due to Alzheimer's. Of the remaining cases, the second most common type is vascular dementia. Due to longer life expectancies and the baby boomer population, the percentage of Americans living with this disease will increase in the coming years. While the management of Alzheimer's disease and dementia is one of the most pressing healthcare challenges in the U.S. today, I'm inspired by advances being made at UCSF to better care for people suffering from these brain illnesses. Be sure to tune into our next episode, in which we explore the latest research, treatment, and education of autoimmune disorders.
The music in this podcast comes from Poddington Bear's Egress, licensed under CC BY NC 3.0, and available at the Internet Archive.